Hey, welcome back. What we're going to talk about in this lecture is chest injuries, and really going to talk about how those affect the patient hemodynamically. At the EMT and AEMT level, there's not a whole lot you can do for closed chest injuries, and we'll talk a little bit about what you do for open chest injuries. Um, so we want to be able to recognize and manage blunt versus penetrating mechanisms. Really going to talk about open chest wounds and how to manage those impaled objects in the chest. We're going to talk about hemothorax, pneumothorax, and the three types of pneumothoraxes that we see the most often in EMS, which is your open, your simple, and your tension. And we'll get into all that a little bit further on in the lecture. We're going to talk about cardiac tamponade, rib fractures, flail chest, and comatose as we move through the lecture. Um, we're going to talk about traumatic aortic disruption. Um, you may see that as a deceleration injury or an aortic tear. We'll talk about pulmonary contusion, blunt cardiac injury, and traumatic asphyxia. The big thing, and what I'd recommend you do, is get you a sheet of notebook paper and all of those injuries that we just talked about. Um, you want to make sure that you know what it is, what it's called, how it happens, and what signs and symptoms to look for, and the treatment. And jot that down on a piece of paper. By doing that, it'll help you retain some of the information. National Registry is going to give you a scenario, and they're going to say, okay, what's going on with the patient, or what do you do for this patient? So you're going to be able to need to decipher that information into a treatment plan. And if you can't recognize what's going on, you're not going to be able to get your treatment plan. You're going to miss the question, fail the test. So thoracic injuries, thoracic is chest injuries, are they're very common, and these can cause really bad issues, even death in your patients. You think about your chest, that's where it happens at. That's where your circulatory system happens at. That's where your respiratory system happens at. That's where your vital organs are. Um, Big thing with the chest is internal bleeding. Um, you can hold your entire blood volume in your chest cavity, and you can hold enough blood in the right or left side of the chest to kill somebody. You can bleed out and die with just the volume of blood that's held in one side of your chest. Um, when you talk about pneumothoraxes, you talk about the collection of air in the chest, and what that does is that pushes everything over, puts pressure on your heart, and causes your heart to stop beating. And we'll talk more about that as we move along. Um, the number one thing that we do for all trauma is we try to prevent trauma. Um, there's not a whole lot we can do, to change the injury patterns that occur. That's up to the patient and up to energy. But what we can do is try to prevent trauma from occurring. So we do gun safety classes, car seat classes, seatbelt training, sports training. Big thing now with football, especially at the high school level, is a heads up tackling where they don't put their head down, where they see their target, those kind of things. Better use of safety equipment, better safety equipment. Thoracic trauma accounts for a significant number of injuries and fatalities every year. The chest is a big part of the body, and when your body's slammed into something or you get hit by a bullet or knife, it's usually in the chest or the thoracic region. And we're going to talk a little bit more about that as we go through. So the anatomy of the chest, the thoracic cavity is divided from the abdominal cavity by the diaphragm, and the chest cavity extends up to the neck. Okay, within your chest cavity, you have your aorta, your vena cavas, your heart, your lungs, and your diaphragm. The mediastinum is the bone in the middle of your chest that your ribs articulate with. Your ribs articulate, some of your ribs articulate with the mediastinum and the spine. Um, so the big bone in the middle of your chest is your mediastinum. It protects the heart, the trachea, and some of those blood vessels. So your anterior chest, the left picture is just a view of the anterior chest. You have your heart here, which is kind of behind your lungs. You have your right lung, which has three lobes. Your left lung has two lobes, which makes room for the heart. diaphragm here, and then you have your ribs that articulate with the sternum, and that piece right there would be the sternum. On the back part of the chest, you have your ribs here that articulate with the spinal column. Um, you have your scapulus, and then you have your intercostal spaces, that's on both sides, but this space right here between your ribs, that's considered your intercostal space. Muscles of the thorax help protect underlying organs. The intercostal muscles, or the muscles, over the ribs, um, they absorb shock. They provide some padding. They expand to pull the chest open for inhalation. They relax to increase that chest pressure for exhalation. The sternocleidomastoid muscles. You see that a lot of times with when somebody has difficulty breathing, you'll see retractions there, and these are your kind of your upper chest muscles. The trapezius rhomboideus and the latissimus dorsi. Um, those are the muscles on the back of your chest, and the pectoralis major surrounds the rib cage, and that's your upper chest muscles on the right side and the left side of the sternum. The trachea is in the middle of the neck. It supplies air to the lungs. That's kind of self-explanatory. The lungs occupy the entire thoracic space except for the mediastinum. Okay, the mediastinum is really where the heart lies at, and the esophagus runs along posteriorly to the trachea, and the esophagus goes to the stomach. It goes through the thorax via the thoracic inlet and travels through the posterior part of the chest, with your trachea being on the anterior portion of the chest. The nerve supplying the diaphragm is your C345. We talked about this in spinal cord injuries. C345 keep you alive. That's what causes your spinal cord to contract and relax. So if you have a spinal cord fracture at C345, your diaphragm is not going to work, and that non-working diaphragm is going to cause respiratory compromise. Ventilation occurs through expansion and contraction of the thoracic cage. What happens is the diaphragm contracts downward, the chest muscles contract outward and pull the chest, decreasing the pressure, making it larger. The chest then, at that point, you then inhale air until pressure is equal. And then once that breath subsides, those muscles relax, decreasing the size of the chest cavity, increasing the pressure of the air inside of the chest, allowing for exhalation. And that's kind of how that process works. This is stimulated by carbon dioxide levels at the medulla and in the brain. Chemoreceptors pick up high levels of carbon dioxide. Then the pons inside the medulla is stimulated to make the diaphragm contract and relax, so you'll take a breath. Pulmonary respiration, and respiration just means gas exchange. Pulmonary respiration occurs at the pulmonary capillary beds. Pulmonary respiration is where carbon dioxide, or CO2, is offloaded from the blood and oxygen is onloaded. Okay? In order for this to happen, you have to have a VQ, ventilation perfusion match. A lot of conditions cause a VQ mismatch. So in order for perfusion to take place, or pulmonary respiration, we have to have that VQ match, which means we have to have enough blood with a pump. We have to have a lack of resistance so that blood can overcome the afterload. Okay? Then you have to have proper lung capacity and the ability of the pulmonary alveoli to connect with the pulmonary capillaries. Cardiac output is delivered to the body. That's the amount of blood delivered to the body in 1 minute. And the way we calculate cardiac output is rate times stroke volume. Stroke volume is the amount of blood ejected with each beat. So the amount of blood delivered over a minute would be your stroke volume times your number of beats per minute. Ventilation is the process of removing carbon dioxide. and that happens through the diffusion. And you talked about diffusion probably your first semester, and that's where gas moves from a level of higher concentration to a level of lower concentration. Chemical changes influence the rate of breathing. A couple things. One, high levels of carbon dioxide increase rate and depth, stimulates your brain to increase the rate and depth. Also, in cases of acute acidosis, the rate and depth may be altered to change pH. And your chemoreceptors, or your chemical receptors in your brain, they detect these changes in chemicals and then change your respiratory rates and depth based on that. Rising CO2 levels are mediated by those chemoreceptors in the brain. Okay, high CO2 levels equal increased rate and depth of respirations. That's your body's response. So slow, shallow respirations would cause an increased carbon dioxide. Deep, fast respirations will cause a decrease in carbon dioxide or CO2 levels. Rising hydrogen ions um, stimulate the chemoreceptors to blow off more carbon dioxide. Carbon dioxide is an acid, so if you have high hydrogen oxide ions, you're going to be acidotic, or going to have a low pH. So by blowing off the CO2, you blow off some acid, and hopefully you raise your pH to normal levels. That's why Kussmaul respirations or deep fast respirations are a compensatory response to diabetic ketoacidosis. Your body's acidic, so you breathe deeper and faster to try to normalize pH. Respiratory alkalosis is the result of hyperventilation. Respiratory alkalosis is the result of hypoventilation. Um, you'll talk more about that in your advanced semester. It's really important to learn your blood gases. They'll follow you throughout your career. Changes in arterial pH can be modified by respiratory rate and depth. We talked about how that happens. A lot of carbon dioxide makes you acidotic. A little carbon dioxide makes you alkalotic. Ventilation changes occur in response to changes in pH. We talked about how that happens. Metabolic alkalosis is just the opposite. You will begin to retain carbon dioxide, so you will breathe slower. And you may even breathe shallower. And all your body's trying to do is normalize pH. So, mechanisms of thoracic trauma. There's blunt and penetrating. Blunt trauma is closed, penetrating is open. Blunt is your chest hit steering wheel, penetrating is your knife, your gunshot, your stab wounds. Visceral or organ injuries may occur. You may also have abdominal injuries to go along with your chest injuries. So, an open chest wound, which is what you see here, is an area where you have a penetrating injury that is open to the inside of the chest. Bubbling, bleeding is a big sign of chest trauma. And what's happening is when you exhale and your body is pushing air out, and when you inhale, your body sucks air in normally. In an open chest wound, the pressures are changed. So remember, during inhalation, um, you typically move air through your trachea. The chest gets bigger, causing negative pressure. You pull air in through your trachea, and it goes to your alveoli. Problem with the open chest injury is when your chest expands, the air goes into the hole and leaks out around the lungs. Okay? When your chest relaxes and you go to exhale, this air remains trapped, and it begins to push the lung over and over, and the lung can't expand. Okay? So on a chest x-ray, you'd have a big old wad of white stuff over here where the lung's been pushed over. Sometimes this pneumothorax can begin to put pressure on the heart, and we'll talk about that later. But this is an open pneumothorax, or an open sucking chest wound. And we'll talk about the treatment for that. If we don't, you take a dressing and you tape it on three sides, and that way you have a flutter valve, so you can lift that valve up and let air escape should you need to. Blunt trauma, you see rib fractures, sternal fractures, and you can have large areas of the chest wall with these fractures. The most common is a rib fracture, but I have seen some sternum fractures. It takes some pretty serious force to fracture the sternum. And then up under that, you may have contusions or bruises to the heart and the lungs. And when you have bruises, that tissue becomes damaged and is unable to do its job like it's supposed to. The skin and the chest wall are not penetrated, so your blunt trauma, the chest wall, the skin remains closed and intact. Broken ribs may lacerate internal organs, including the heart, the lungs, the aorta. You can also have lacerations to the liver or the spleen from your rib fractures. Vital organs can be torn from their attachment. We see this a lot with the aorta. Forcible trauma, that blunt trauma to the aorta, can cause a deceleration injury, and the aorta will actually rip away from the heart. Those patients typically die instantly. You can also have shearing from the aortic shearing is where it rips off the heart. You can also have shearing to the liver, and that will cause massive internal bleeding. Blast injuries can be classified as blunt or penetrating. Remember your blast injuries. Phase 1 is your pressure wave. Phase 2 is your flying objects. Phase 2 is where you get your impalements. Phase 3 is where your body flies into something, and phase 4 is your burns, your smoke, your chemicals, your building collapse. That's also known as primary, secondary, tertiary, and quaternary blast injuries. Thoracic trauma may impair cardiac output. You can have pressure on the heart from internal air or bleeding. You can also have cardiac contusions, and you can also have rhythm changes from disruptions to the electrical system of the heart. Injury to the chest can be lethal. That's where your heart and lungs are. This stuff really, really matters because if you hurt your heart or lungs, you'll have some serious complications, maybe death. Bleeding into the thoracic cavity increases the chance of hypovolemia and hypoxia. That bleeding will prevent the lungs from touching the pulmonary capillary bed for gas exchange. That bleeding will also prevent pulmonary expansion. And you can lose a lot of blood in your chest. You have lots of veins and arteries there. And your chest cavity can hold your entire blood volume. And you only need to lose about 40% of your blood volume to have death. Blood in the pericardial sac is called a pericardial tamponade. And every time your heart beats, that blood puts more and more pressure on the heart. And it reduces its ability to expand. And eventually, when the pressure inside of that pericardial sac meets your heart's expansion pressure, blood flow will stop. And remember, the heart has to expand and contract hard enough to overcome afterload. So once you meet mean arterial pressure, or once you can't overcome afterload, your heart will not be able to pump blood out and you'll die. And you have vascular disruption. This is your tearing, your shearing injuries of your arteries. And that's just an occlusion of your blood vessels. Or it can be an open laceration of those blood vessels. Impairments to ventilatory efficiency may be rapidly fatal. Obviously, if you're not breathing right, you're going to decompensate faster. Air exchange and oxygenation decreases with injuries to the chest. You think about rib fractures, the patient has a hard time taking a deep breath. That compromises respiration. Bleeding, pneumothoraxes with those pressure changes can compromise respiration. And diaphragmatic injuries, diaphragmatic ruptures or tears can cause you to not be able to breathe effectively. We're going to aggressively manage these patients' airways. Patients with severe chest pain will breathe shallow, which reduces your minute volume, which reduces your oxygenation. And in pneumothorax is the space created between the two pleural surfaces, which means the lung is not expanding because it's being pushed down by the air, so it's unable to connect with the pulmonary capillaries. And then hemothorax, you have blood, and gas exchange cannot occur between that free blood. It puts a barrier between the alveoli and the pulmonary capillaries. Atelectasis is where the lungs collapse. We see this a lot of times in neonates, but the reason that your ventilators have PEEP on them is to keep the lung expanded during ventilation. If you put an advanced airway in, the epiglottis keeps a physiological or normal PEEP of about 5, which keeps your alveoli open. If you put an advanced airway in, you take that PEEP away. So every time you give a breath, the alveoli are going to completely deflate, and that can cause the lungs to collapse and cause atelectasis. We see atelectasis in babies because they don't have enough surfactant to hold their lungs open. But the atelectasis, or the collapsing of the lung, reduces the surface area available for gas exchange, and without gas exchange, you get your blood becomes hypercarbic and hypoxic, and you basically go into an anaerobic metabolism from not having the oxygen for cellular gas exchange. A bruised lung can cause hypoxemia. The bruised area may not participate in gas exchange, depending on how severe the bruise is. Um, Disruption of the respiratory tract can prevent oxygen from reaching the alveoli. This would be your tracheal ruptures, your blood in your trachea, your bronchial tears. Those kind of things will prevent air from getting to the alveoli and would result in cellular hypoxia. So what are some signs and symptoms that we look for? We look for pain localized at the site of the injury. And if it gets worse with breathing, then we know there's some kind of serious chest injury going on. If you see bruising, that means there's been enough force to cause bleeding under the skin. So we need to keep that in mind as to what the internal injuries could be. Crepitus means that you got some broke bones. Usually that's your ribs, could be your sternum. But that crepitus lets you know that chest wall isn't working, and the negative pressure system may be failing, so you may have to move into a positive pressure system. Dyspnea, that's difficulty breathing. Uh, Hemoptysis, that's the spitting up of blood. Failure of the chest to expand with inspiration, or seesaw breathing. One side may expand, one side may not expand. Rapid weak pulse and low blood pressure. That gives you a high index of suspicion that you're losing a lot of blood in your chest cavity. And cyanosis, first place you'll see it's around your lips and your nail beds, the palms of your hands. You start seeing cyanosis, you start thinking of a compromised chest, compromised respirations. Changes in breathing after chest injury is an important sign. Remember, normal respiratory rate is between 12 and 20 breaths per minute. Anything outside of that is considered abnormal. Anything under 10 or over 28 is considered to be inadequate. So make sure you're watching your rate, and if you see shallow breathing or rate changes, make sure you have a high index of suspicion of chest trauma. And patients may present with bradypnea and labored respirations, that's slow respirations, and a lot of times it's because of a neurological injury, but it can also be from a chest injury because the patient is not wanting to breathe because of the pain. Dyspnea, that's difficulty breathing, is caused by airway obstruction, damage to the chest wall, that's typically your rib fractures. Could be your open sucking chest wounds from the wound itself, but typically it's going to be your rib or sternal fractures. Improper chest expansion, hemothorax, pneumothorax causes improper chest expansion. Pressure and rib fractures don't hold that chest wall open, so you lose the ability to expand. And then lung compression, that's from the lungs slamming into the spinal cord. If it remains compressed, it's not going to be able to expand. And that compression can also cause pulmonary hematomas. Hemoptysis, spitting up or coughing of blood. That means the lung tissue is damaged. So the alveoli have been injured, and you are actually bleeding blood into your alveolar sacs. And you may have blood in your bronchial tracheal passage from a bronchial or tracheal tear, and the patient will cough up blood in those situations too. Presence or absence of a pulse, a rapid weak pulse, and hypotension are signs of hypovolemic shock, which could include bleeding in your chest. Absent radial pulses cause severe hypotension. That means your systolic blood pressure is below somewhere between 80 and 90. I think the new text says if you lose your radial pulse, your systolic blood pressure is more than likely below 80. And a tachycardia may end up, maybe an indication of hypoxemia or compensatory shock. So remember, your tachycardias are very, very important to watch. and make sure if your patient shows tachycardia that you are checking for all of those underlying injuries. Changes in blood pressure. Hypertension is a result of increased sympathetic discharge or release of catecholamines or adrenaline. And what happens is when you get cut or hurt, your body releases adrenaline. You get vasoconstriction and increased heart rate, which increases your blood pressure. Hypotension and hypovolemia is a late sign of shock. So you want to make sure that you're monitoring and managing that. And then if you have lots of pulses during inspiration, that means that you may have some kind of increased pressure in your chest. Usually that's caused from a pericardial tamponade, and that's called pulsus paradoxus. That's when you have a decrease in pulses when you inhale. They'll also typically increase rate by a few beats when you inhale, but that's called pulsus paradoxus. We see it a lot with pericardial tamponades, and we see it in our COPD patients as well. And diaphoresis or pallor, that's sweating and paleness, that's from vasoconstriction. Cyanosis is a sign of inadequate respiration. Peripheral vasoconstriction with your diaphoresis and your pallor is a sign of shock. So your patient assessment is the same as it is for any other types of injuries. Make sure you're seen safe, take care of yourself, take care of your partner, make sure you use the proper protective equipment. If you have external bleeding, spurting of blood, you want to make sure you got your gloves, your goggles, your gown, your face coverings, those kind of things. Find out how many patients you have and perform triage. And remember, in mass casualty situations, we do the most good for as many people as we can. Make sure you pick your most critical patients first, or the ones that you can help the most first, and take care of those. In non-mass casualty situations, we typically care for the most critical patients first. Get additional resources. Really consider your ALS backup. Paramedics can do things like do advanced airways, chest needle decompressions for our chest injury patients. And a chest needle decompression can be the difference in life and death for a pneumothorax. And consider C-spine if your energy is there, your kinetic energy, and you suspect a neck fracture. Make sure you manage your C-spine. Get your general impression. Get your level of consciousness. Is the patient responsive? If they are responsive, are they altered? Do they have changes in their GCS score? And do your rapid exam. Look for obvious injuries. Blood. Is the airway open? Is it patent? Are they having difficulty breathing? Do you see cyanosis? Is the breathing regular or irregular? Do you have chest rise and fall on either one side? That's why lungs are clear and equal bilateral. We have bilateral chest rise. That's normal. Anytime you have unilateral chest rise and fall or unilateral breath sounds, then you know you have some serious issues. Accessory muscles in the neck. Do you have an increased work in breathing? And if you have jugular vein distension, that's from increased pressures inside of the chest. So jugular vein distension means that you have a pneumothorax, pericardial tamponade, pulmonary embolus, one of those conditions that causes the chest to have an increased blood pressure. Your general impression is important. That's what will let you know if you need spinal immobilization, what kind of injuries you may be working with. Penetrating wounds to the neck, you want to check the trachea. And during our trauma assessment, we ask if the trachea is midline. And the way I remember it is the trachea will run from the side of the pneumothorax. So the pneumothorax will actually push the trachea over, push it away from it. So that pneumothorax, if you see that tracheal deviating, it is deviating or moving away from the side of the collapsed lung. And is breathing adequate? If the patient is breathing inadequate, you need to do aggressive airway management. And do your DCAT BTLS, inspect, palpate, auscultate the chest, look for equal expansion, look for retractions or using accessory muscles. Do you have absent breath sounds? Absent breath sounds could be pneumothorax, hemothorax, pulmonary contusion. Do you have diminished breath sounds? That just means the injury hadn't progressed as far to make absent breath sounds yet. And do you have paradoxical motion? And that's we see that a lot with flail chest, and that's where when the chest expands, one segment or section of the chest gets sucked in, and as the chest relaxes and gets pulled in, that section gets pushed out. That's paradoxical movement. And that's just where one segment of the chest does not move in tandem or in sync with the other section. And a flail chest is 2 or more ribs broken in 2 or more places, and that can cause respiratory compromise because that area of the chest is not allowing for expansion. Cover any open wounds with a gloved hand. Any open chest wound is considered a life threat, and your gloved hand will create an occlusive dressing, and it'll stop that air from leaking out or being sucked in from the outside. So we want to immediately get that gloved hand on it, and then put an occlusive dressing on all penetrating injuries. And if it's a sucking chest wound, we're going to tape that dressing down on 3 sides, so as we'll have that corner for a flutter valve. All these patients get a non-rebreather at 15 liters a minute. We want to make sure that the blood has plenty of oxygen to carry to the cells. And watch your mental status, watch your GCS changes. That will let you know if there's some form or some underlying injury to the brain or spinal cord. That can also let you know if the patient's in shock and has adequate perfusion to the brain. Listen to your heart sounds. Muffled heart sounds will let you know that there's a pericardial tamponade. And those are your hyporesonant sounds for your heart. That we call them muffled heart tones, but they're hyporesonant, means blood is filling up around the heart. We also talk about hyperresonant when we talk about a pneumothorax. If you percuss the chest where the lungs are and the sound echoes or sounds like a drum, that is a hyperresonant sound. That means you have a pneumothorax or air in the chest. If you percuss on the chest and you hear a dull thud sound, that's a hyporesonant sound, and that means you have blood in your chest. Jugular vein distension is the jugular vein where it's engorged or poking out right there. That means there's increased pressure in the chest. Pulmonary embolus, congestive heart failure, pericardial tamponade, and pneumothorax lets you know there's increased pressures in the chest. We don't see jugular vein distension with hemothoraxes or blood in the chest, because by the time you get that much pressure in the chest, you don't have enough blood volume to cause those jugular veins to pop out and be distended. Alright, so we're going to stop right here. It's been 30 minutes into the lecture. We'll pick up the lecture in just a few minutes. For some reason, I'm having issues with the videos, so you may have to skip the first 2 or 3 minutes of the video before the lecture part actually begins. I think it's playing the beginning parts of the slideshow. So we're going to stop here. Y'all take a break, take a breath, go get something to drink, and come back and we'll finish up the lecture.